It was a fantastic session and lots of great discussion. And I think with all of the evolution of myeloma, both in frontline and the late relapse setting, we tend to forget how complicated now early relapse has become. So in our session, we had focused on early relapse with multiple case studies to guide our discussion based on the reality now that our frontline therapies are changing for myeloma. We're almost definitely including a CD38 antibody in frontline therapy, whether someone's going to transplant or not. Almost everybody is on at least lenalidomide maintenance and often dual maintenance at that first relapse. So much of the discussion focused on what is the strategy, what is the approach in early relapse. And ultimately, we came up with a sort of a few guiding principles. Principle number one was that, of course, we like to change the mechanism of action. So if someone has been on lenalidomide maintenance, we don't use lenalidomide in the relapse setting immediately. And so we have now many phase 3 trials that guide us. Whether someone's on lenalidomide alone or lenalidomide plus a proteasome inhibitor, or very often lenalidomide plus daratumumab or isatuximab as a CD38 antibody. And so thankfully, we have a lot of evidence to support that, and we do want to change that mechanism of action. Secondly, we want to make decisions based on the frailty and comorbidities of the patient. We don't just have a simple algorithm in myeloma anymore, where we say we always give this first line, always give this second line, always give this third line. We modify that based on the factors, and the factors of that patient is really important. Thirdly, we modify based on patient preference. It's so important to talk to our patients about their own definition of quality of life. And do they want to come in once or twice weekly for an IV or a subcutaneous infusion? Would they rather be on an all oral regimen? Those kinds of things become very important, or the potential side effects that they may experience. Now that we have such a laundry list of options, we can make that modification. And then lastly, I would say principle number 4 is that as we're introducing earlier line therapy, CAR T-cell therapy in particular, and likely bispecifics not too far from now, it's always important to risk stratify our patients into the sort of higher risk versus standard risk, because that may modify our choice as well. Right now in the US, we tend to be preferentially prioritizing the highest risk patients, in particular those that have functional high risk with very rapid relapse, towards these therapies, as opposed to that patient that may have gone into remission for 3, 4, 5 years. And so all of this reflects the biology of the disease and the choices that we have. So it's really a fantastic session with multiple speakers sharing different cases, lots of great discussion. And I think these principles were the ones that ultimately we concluded. And I think hopefully will guide those clinicians as we care for our patients with early relapse in myeloma.